Welcome. I'm Dr. Len Calabrese from the R.J. Fasenmyer Center for Clinical Immunology. This is another installation of Rheumatology Virtual Grand Rounds. This is special for me because our speaker, Atul Khasnis, is a former trainee of ours who completed rheumatology at the Cleveland Clinic Foundation, completed his vasculitis fellowship at the Cleveland Clinic, and now is a staff physician both in the Center for Vasculitis Care and Research and the Fasenmyer Center for Clinical Immunology. I've asked Atul to craft an interactive presentation on the importance and the nuances of making an accurate diagnosis of systemic vasculitis. Atul?
Hello and welcome to Rheumatic Disease Virtual Grand Rounds. My name is Atul Khasnis. I'm one of the staff in the Center for Vasculitis Care and Research at the Cleveland Clinic. And today we are going to be talking about detecting vasculitis before it's too late. So as all of you are aware, the primary systemic vasculitic diseases are fairly rare, but when they are present, it's important to detect them early and treat. So the learning objectives for this presentation are to discuss clinical presentations that can aid the recognition of systemic vasculitis, also discuss the approach to diagnosing these diseases, and going a little bit over recognizing vasculitis mimics. So how do we define vasculitis? Simply put, it's inflammation of blood vessels, and inherent in this definition is the fact that in true systemic vasculitis, you actually see immune cells within the wall of the blood vessel with resultant damage. So it's not enough to have a few lymphocytes or immune cells around the blood vessel which is intact, but you actually see destruction of the vessel wall architecture by these immune cells. And as for other rheumatic diseases, the diagnosis is made by a combination of compatible clinical features, labs, imaging, and histopathology results. This is just as it's applicable to other rheumatic diseases as well. So let's start out by talking about why a delay in diagnosis might be common. So the most likely cause for this is that symptoms are often vague and protean, especially in the early stages of vasculitis. Patients may present with non-specific symptoms such as low-grade fever, weight loss, malaise, myalgias, not really pointing to a specific organ system or a particular etiology. It's also very true that the symptoms that finally do lead to the diagnosis of vasculitis are more likely from a non-vasculitic etiology, such as sinusitis is more likely from a viral or a bacterial infection rather than from GPA or Wegener's, or a headache is more likely from other etiologies than from giant cell arteritis. And finally, the physician threshold for diagnosis may be set too high, so vasculitis is not considered early enough in the differential. Let's look at some of the statistics regarding delay in diagnosis of vasculitis. So from a paper by Dr. Hoffman et al. Back in 1998, the median delay to diagnosis of GPA or Wegener's was 16.8 months. However, a more recent editorial by Almeini et al. In Journal of Rheumatology in 2006 mentioned that the median time to GPA diagnosis might have been decreased due to increased physician awareness and the availability and use of ANCA testing. Again, an older retrospective review in 1996 from the Northwest Glomerular Disease Registry showed that the median delay to diagnosis of glomerulonephritis associated with primary systemic vasculitis was about 3 months. And in the large vessel vasculitis domain, a review by Dr. Hoffman et al. Back in 1994 reported that the median delay to diagnosis of Takayasu arteritis was about 10 months. So we all know that we should be diagnosing vasculitis early, and the main reasons are that these are pretty severe diseases. So back in the 1970s or before that, when we did not have good treatment for the diagnosis of GPA, it was reported that 82% of patients with active GPA died within the first year. Also, we know that the delay in diagnosing glomerulonephritis is associated with an increased risk of developing end-stage renal disease and the need for dialysis, which is a major morbidity and is associated with its own complications. Other morbidities that can result from organ damage can also leave the patient with a significantly impaired quality of life, such as alveolar hemorrhage that can lead to pulmonary fibrosis, or nerve damage that can lead to persistent neurologic deficit. And finally, we know that these diseases are severe enough that they can also be potentially fatal. So let's start with a few cases. So this first case is a 30-year-old male who presents with fatigue, diffuse joint pain, and dry cough of 4 weeks duration. He denies any hemoptysis. On exam, his blood pressure is 106/68. He's slightly tachycardic, a slightly increased respiratory rate. He looks tired. There's no synovitis on joint exam. His lungs are clear, and his oxygen saturation is 90%. The rest of the exam is non-contributory. Labs show that his hemoglobin is 11. He has slight leukocytosis. His ESR and CRP are elevated, and the chest X-ray shows a mild infiltrate at the right base. Previous labs show that 2 months ago his hemoglobin was 14. So the question is, what should be done next? A, observation with plan to follow up in a week for presumed viral bronchitis. B, treat with an antibiotic for presumed bacterial pneumonia. C, admit and evaluate for concern of diffuse alveolar hemorrhage. D, symptomatic treatment with antitussives. Go ahead and make your selection. So the correct answer here is C, admit and evaluate for concern of diffuse alveolar hemorrhage. So in this young, previously healthy individual presenting with a drop in hemoglobin, slight hypoxia, and a new infiltrate on the chest X-ray should raise concern for alveolar hemorrhage. So alveolar hemorrhage can occur unpredictably. It should be suspected, especially in patients with this clinical triad of drop in hemoglobin, infiltrate on chest X-ray, and significant hypoxia. Only 50% of patients with alveolar hemorrhage present with hemoptysis, so this is not required to suspect the diagnosis. Once suspected, it should be aggressively evaluated and treated. Mortality rates from different series range from 23 to 92%, so this is a pretty serious manifestation. It's important to exclude other causes before initiating immunosuppression because, again, primary systemic vasculitis is not the only cause for this complication. In patients who are started on standard of care immunosuppression but do not respond, plasmapheresis may have to be added to the treatment regimen. And most importantly, close follow-up is warranted after the initial episode because recurrences can happen. When you look at diffuse alveolar hemorrhage syndromes, the common diseases that are associated with this are primary systemic vasculitic diseases such as microscopic polyangiitis or MPA and GPA or Wegener's. It's much less likely to happen in Churg-Strauss syndrome, and other diseases which are associated can be like Goodpasture syndrome and within rheumatology, lupus. Let's look at case 2. This is a 48-year-old male presenting with fatigue, sinusitis, fullness of the ears, migratory joint pain, and a dry cough for 2 to 3 months. He has received antibiotics thrice without change in his symptoms. On exam, his nasal mucosa is ulcerated, he has bilateral middle ear effusion, sinus tenderness, and synovitis of the MCP joints. His lungs are clear to auscultation. Labs show that he has an anemia with a hemoglobin of 11, leukocytosis, thrombocytosis, elevated ESR and CRP, a positive rheumatoid factor, negative ANCA serology, and a normal creatinine and a urinalysis. His CAT scan of the chest shows lung nodules, as shown here on the left lung, the largest measuring 2.2 centimeters. A bronchoalveolar lavage and transbronchial biopsy exclude infection, and he started on treatment for presumed GPA with methotrexate and prednisone, and he responds to therapy as expected. So the question regarding this patient is, how should this patient be monitored? A, laboratory blood tests every month. B, laboratory blood tests every month with urinalysis. C, laboratory blood tests every 3 to 6 months since he is on stable immunosuppression and felt to be in clinical remission. Or D, test only when there is clinical relapse. Go ahead and make your selection. So the correct answer here is B, laboratory blood tests every month with urinalysis. So although this is a patient who has been diagnosed previously with GPA and is doing well and responding to treatment as expected, one can never lower one's guard too much about the possibility of relapse in these patients. It's also important to follow them closely with blood tests as well as urinalysis because it can help in detection of return of disease activity as well as drug toxicity. So in this case, the prednisone is tapered down to 5 milligrams per day, and he continues on methotrexate. He's continuing to get monthly labs with urinalysis and continues to be asymptomatic. A year later, his urine shows large blood and 2+ protein, and his urine microscopy shows RBC casts. His serum creatinine has now risen to 1.8 milligrams per deciliter. A kidney biopsy shows posse-immune presenting GN, and he started on treatment with IV methylprednisolone followed by high-dose oral prednisone and oral cyclophosphamide for relapse of GPA. With this treatment, his creatinine improves to 1.1 over the next 4 months. So we know from the seminal paper by Dr. Hoffman et al. Back in 1992 that renal involvement in GPA occurs in 20% of patients at onset and in 80% over the course of the disease. So urinalysis is a cheap and effective means to detect relapse in GPA involving the kidneys early, because this really is quite an asymptomatic involvement from GPA, and patients really will not present with symptoms until they are into advanced renal failure. In fact, patients without initial renal involvement should be taught urine home dipstick testing so that they can pick up an early renal flare themselves and alert their physician. If the patient does report the appearance of blood on dipstick, this should be verified by formal urinalysis and urine microscopy. And why do all this? Because we know that early detection can help preserve renal function. Moving on to case 3. A 50-year-old lady presents with symptoms of fatigue, joint pain, and muscle pain. Weight loss for the last 6 to 8 weeks. About 2 weeks ago, she developed a tendency to trip and fall, especially when using her left foot. She has also noticed a net-like pattern on her lower extremities, but she denies any abdominal pain. On examination, she looks fatigued. She's hypertensive, tachycardic, has a livedoid pattern on her legs, and a left foot drop. On your neurologic exam, you also find she has slight weakness of dorsiflexion of the right wrist. She has no rash, synovitis, or lymphadenopathy, and her lungs are clear. Labs show that she's anemic. She has leukocytosis, thrombocytosis, elevated ESR and CRP, a normal creatinine, and UA shows 1+ protein with no blood. So the question is, what should be done urgently? EMG testing and sural nerve biopsy, and start treatment only if the biopsy shows vasculitis. B, ANCA testing to make the diagnosis of vasculitis. C, renal biopsy for new onset proteinuria and hypertension. Or D, start treatment with high-dose glucocorticoids and cyclophosphamide after reasonably excluding infection. Go ahead and make a selection. So the correct answer here is D, start treatment with high-dose glucocorticoids and cyclophosphamide after reasonably excluding infection. So the clinical picture in this case is compatible with a diagnosis of a medium vessel vasculitis in a patient presenting with joint pain, systemic symptoms, new onset hypertension, a livedoid rash, and most importantly, a picture of mononeuritis multiplex involving the left foot and the right wrist. So mononeuritis multiplex should raise significant concern for vasculitis, and urgent immunosuppression is indicated after reasonably excluding infection. Even in patients in whom medium vessel vasculitis or small vessel vasculitis is associated with hepatitis B or hepatitis C infection, immunosuppression is indicated concomitant with antiviral therapy. Renal biopsy is not indicated in patients suspected to have medium vessel vasculitis and may even be dangerous because we know that patients with polyarteritis nodosa can have renal artery microaneurysms, and a puncture of this aneurysm during renal biopsy can be associated with significant bleeding. ANCA testing has absolutely no role in medium vessel vasculitis. It's important to have a discussion with patients up front that most patients will experience some residual damage from the mononeuritis. The sensitivity of a nerve biopsy from a symptomatic site for the diagnosis of mononeuritis is 71%, and from a blind site is 19%. So it's not recommended to do biopsies on tissues that are not clinically involved. And in fact, remember that a nerve biopsy can be associated with significant morbidity because the patient can have persistent numbness or paresthesias in the area of the biopsy, leading to affection of quality of life. The other important point to remember is that the most reliable evidence of disease progression from the neuropathy standpoint is involvement of nerve in a previously unaffected territory, which means that, like in this patient, if she already had a left foot drop, it is difficult to assess disease activity based on symptoms just in the left lower extremity. So the most reliable evidence of disease progression would be that she develops neuropathic symptoms in the right foot or in the left arm, which have not been previously involved. So looking at vasculitic neuropathy in the setting of primary systemic vasculitis, this paper looking at 506 patients from the European Vasculitis Study Group noted that 18% of these patients had vasculitic neuropathy at baseline. Of this, only 35% had complete resolution within 6 months, which means that most patients do continue to experience some neurologic deficit or symptoms in that area. And the cumulative prevalence over 5 years was about 15%. When we look at vasculitic neuropathy occurring in systemic vasculitic diseases, the most common causes are the primary systemic vasculitides like Churg-Strauss syndrome, polyarteritis nodosa, microscopic polyangiitis, and GPA. But it can also be associated with secondary vasculitic diseases such as rheumatoid vasculitis, hepatitis B-associated PAN, and hepatitis C-associated PAN, and cryoglobulinic vasculitis. Let's do case 4. A 30-year-old previously healthy lady presents with new onset persistent generalized headaches for 4 months. The headache is worst in the morning and maximal in the occipital region. She also gets occasional visual blurring, but she denies any aura, photophobia, nausea, vomiting, or jaw claudication. She has no sinus symptoms, and her eye exam is normal. She denies any other symptoms except for mild fatigue, and she has been tried on multiple therapies for the headache, including treatment for migraine. On exam, the only notable finding is a low blood pressure of 97/60 in her right arm and a soft epigastric bruit. Her labs are normal, and you ask her about the low blood pressure in the right arm, and she tells you that her blood pressure has always run low when it has been checked in the right arm. So what should you do next? Recommend hydration for low blood pressure, do a 4-extremity blood pressure check in the office, and repeat a closer vascular exam for evidence of bruise in other areas, refer her to the headache clinic, or start her on a different non-steroidal or pain medication. Go ahead and make your selection. So the correct answer here is B, check for extremity blood pressure in the office and do repeat a closer vascular exam. So in a young patient like this presenting with headaches with evidence of low blood pressure in one arm, it's important to make sure that this is really low and not pseudo-hypotension that could result from vascular stenosis in that arm. Also, the presence of bruit in one area should make you go back and examine for bruits in other areas, which could also increase the chances of finding vascular occlusions in other territories. So you do a 4-extremity blood pressure evaluation, and her right arm is low, but her left arm blood pressure is 190/105, the right leg is 190/98, and the left leg is 184/100. On your repeat vascular exam, you also detect a soft right subclavian bruit. You proceed with vascular imaging, which then shows that she has right subclavian artery stenosis and a left renal artery stenosis. So again, in a young individual presenting with this clinical picture, it does raise the possibility of large vessel vasculitis, most commonly Takayasu arteritis. So 4-extremity blood pressure measurement in the office can help detect vascular stenosis early, as well as detect hypertension, which can be picked up by measuring blood pressure in the other extremities. In patients with known extremity vessel stenosis, such as the subclavian, iliac, or the femoral arteries, blood pressure measurements are only reliable in extremities without narrowed vessels, which means in a patient with bilateral subclavian artery stenosis, the only reliable blood pressures would be in the lower extremities. Hypertension is a significant comorbidity in patients with Takayasu's and may necessitate intervention for the renal artery stenosis if the blood pressure remains uncontrolled on medical management. Even after intervention, the blood pressure may continue to remain elevated and require antihypertensive therapy. ESR and CRP, which we use as markers of inflammation, do not always correlate with disease activity in Takayasu's and should not be used in isolation to judge disease activity. Again, like we talked about neuropathy in medium and small vessel vasculitis, for large vessel vasculitis, the most reliable evidence of vascular disease progression is involvement of the artery in a previously unaffected territory, which means that if this lady had right subclavian artery stenosis, it's difficult to assess disease activity based on serial vascular imaging just in that territory. And the more reliable evidence of disease progression would be development of vascular stenosis in the left subclavian artery or in the arteries supplying the lower extremities. In this paper that looked at patients with Takayasu to look at patterns of vascular involvement, comparing two cohorts in the US, one from the Cleveland Clinic and one from the NIH, with cohorts from Italy, Japan, India, and Mexico, the pattern of vascular involvement in the US most commonly does involve the subclavian arteries. The left subclavian artery is involved in about 90%, and bilateral subclavian artery involvement occurs in about 60% of patients with Takayasu's. When you look at morbidity associated with Takayasu's, again in the American cohorts, 20 to 30% of patients will develop hypertension and have that as a morbidity associated with this disease. So it's important to recognize and treat this comorbidity. So what are some of the clinical clues that should alert you to the possibility of a primary systemic vasculitis? Fever of unknown origin, mononeuritis multiplex like we saw in a previous case, rapidly progressive glomerular nephritis, palpable purpura, diffuse alveolar hemorrhage, as we also saw in an earlier case, pulmonary renal syndrome, unexplained infarction in multiple vascular territories, and unexplained multisystem disease. All these are possibilities that should alert you to the probability of primary systemic vasculitis. Let's look at a couple of other cases. A 42-year-old lady presents with history of abdominal pain 6 months ago. The pain was localized to the epigastrium, unrelated to meals, and there was no specific precipitating or relieving factors. She has no previous illness and no other symptoms at this time, so the abdominal pain has resolved. On exam, she has a thin build. Her cardiovascular exam reveals a soft early diastolic murmur in the aortic area. All her peripheral pulses are well felt, extremity blood pressures are equal and symmetric, and she has no bruise. Her labs are normal. Abdominal ultrasound shows an abdominal aortic aneurysm measuring 4.2 centimeters. You proceed with non-invasive vascular imaging, and it shows a dilated aortic root measuring 4 centimeters, a dilated ascending aorta measuring 3.5 centimeters, the abdominal aortic aneurysm measuring 4.2 centimeters, and also an aneurysm at the origin of the celiac trunk. There are no vascular stenosis noted on the imaging, and the radiologic report does mention vasculitis in the differential diagnosis. So what is the next best step? Start prednisone 60 milligrams daily, suspecting large vessel vasculitis. Do genetic testing for connective tissue matrix disorders. Obtain a dye arteriogram to assess the aorta and its branches, or refer to cardiothoracic surgery. Go ahead and make your selection. So the correct answer here is genetic testing for connective tissue matrix disorders. So again, in a patient presenting with pure aneurysmal vascular disease, it's important to think of possibilities outside of vasculitis, because most patients with large vessel vasculitis will either present with stenotic vascular lesions or a combination of stenosis and aneurysms, but much less likely with pure aneurysmal disease. So based on the pure aneurysmal nature of her disease, you refer her to medical genetics, and genetic testing reveals that she has a mutation in the type 3 procollagen gene associated with type 4 Ehlers-Danlos syndrome, which is of the vascular type. Let's do one more final case. A 35-year-old lady comes to your office for complaints of persistent sinusitis. She has intermittent bloody nasal discharge and some nasal crusting. She denies ever having any pulmonary symptoms. On exam, she has a depressed bridge of the nose, crusting of the nasal mucosa, and a nasal septal perforation. Her skin and lung exam are normal. Her labs are essentially normal, except for a positive ANCA PR3. She has been on prednisone 40 milligrams daily and methotrexate 20 milligrams per week for 3 months without any change in her symptoms. What should you do next? So your options are A, change methotrexate to cyclophosphamide for resistant GPA. B, change methotrexate to azathioprine for non-severe resistant GPA. C, refer to ENT for evaluation and biopsy with culture and polarizing microscopy. D, treat with an antibiotic for superinfection while continuing the methotrexate and prednisone. Go ahead and make your selection. So here the correct answer is C, refer to ENT for evaluation and biopsy with culture and polarizing microscopy. So this is a young lady presenting with symptoms that are localized just to the nose and the sinuses. She does have a nasal septal perforation, but the most important red flag in this case is that she has been treated with reasonable immunosuppression with prednisone and methotrexate for 3 months without any changes in her symptoms. So whenever this happens, you should always take a step back and reevaluate the situation. In this case, this patient was referred to ENT, and biopsy was negative for any infection, but the polarizing microscopy did reveal that she had crystals of cocaine in her nasal mucosal biopsy. So all of you are aware of disease associations with ANCA positivity, but just to go over it briefly, C-ANCA positivity can be associated with most strongly with GPA, but also other diseases like Churg-Strauss syndrome, idiopathic rapidly progressive glomerulonephritis, infections such as amoebiasis, other diseases such as Goodpasture syndrome, and cocaine use. The P-ANCA positivity, again, is much less specific, and although can be associated with the primary systemic vasculitic diseases, is also known to be associated with rheumatoid arthritis, lupus, inflammatory bowel disease, and many other disorders. So why is misdiagnosis of vasculitis common? So converse to what we talked about in the delay of diagnosis of vasculitis, where vasculitis is considered too late in the differential, the possibility for misdiagnosis increases when vasculitis is considered to be the only diagnosis. And this can happen either because of inappropriate serologic testing or over-reliance on a laboratory test result like a positive ANCA, or using a single modality like a radiologic finding of arterial stenosis to make the diagnosis of vasculitis. So it's most important to go back and look at the whole picture in terms of the clinical picture, laboratory evaluation, imaging, and histopathology when possible to make the diagnosis. The first question you should ask yourself whenever evaluating a patient for vasculitis or thinking about vasculitis is it a primary systemic vasculitis? Because it's imperative to look for secondary causes as well as look for mimics of primary systemic vasculitis. And conditions that can be associated with mimics of primary systemic vasculitis include infections, atherosclerosis, hypercoagulable disorders, inherited disorders like we saw, malignancy, especially even intravascular malignancies, vasospastic disorders as can be seen with reversible cerebral vasoconstriction syndromes as a differential of primary CNS vasculitis, immunodeficiency, and miscellaneous non-inherited disorders. So to summarize, the primary systemic vasculitic diseases are serious diseases that warrant early recognition and immediate treatment because we know that delayed diagnosis can lead to significant morbidity and even mortality. Like I said, it's most important right at the beginning to evaluate for secondary causes or an alternative etiology like mimics of primary systemic vasculitis. Remember that immunosuppression is fraught with significant risks, so we should use it only when it's justified. And most important, if the response to therapy is atypical, it's important to step back and reevaluate and not just escalate immunosuppression because that would increase the risk of infection and other complications for the patient. Thank you for your time and attention.
Thanks, Atul. That was really terrific. You know, I think for both the generalist and the subspecialist, the diagnosis of vasculitis is a challenge. It is within the differential diagnosis of so many classical presentations, as you have pointed out, particularly the FUO. When we think of FUO, we think of infection, malignancy, and inflammatory diseases. And over the past 40 years, we've been increasing our diagnostic accuracy at so many conditions, yet vasculitis still remains a perplexing member and increasing in its prevalence within this differential diagnosis. I like your other cues to the presence of vasculitis, including suspicious skin rash, unexplained axonal polyneuropathy, and always in the differential diagnosis of unexplained RBC casts in the urine or glomerulonephritis. I also want to emphasize the importance of a timely diagnosis, particularly with hyperacute presentations. I'd like to ask all of you to come back to Rheumatology Virtual Grand Rounds again. We're going to have many other exciting presentations up this year on many perplexing problems. Thanks. This is Dr. Len Calabrese.